Please, Mrs. Lorsch, welcome to Zurich.
Thank you very much. Thank you. I'm very much looking forward to April 1st, and then I will be here located, and I'm looking forward to work with the urologists and the medical oncologists. So thanks a lot for introducing me today and to give me the possibility to moderate the next session we have. This will be bladder cancer, and it is my pleasure to introduce Alexander Zlotta from the University of Toronto, who will give us a talk about non-muscle invasive bladder cancer patients and what to do if BCG fails in these patients. I'm looking forward to your talk.
Thank you. Thanks. Good afternoon. It's a real pleasure to be here, and certainly thanks to Thomas, Cedric, Tullio. You see, Thomas spent a couple years working hard, partying hard as well, in Toronto, and he has been instrumental, actually, to the multidisciplinary bladder cancer clinic. We have a really clinic just dedicated where medical oncologists, radiation oncologists, surgeons see patients, and we do think this really has improved things for their management. Essential in the propensity analysis comparing cystectomy and trimodality, where Thomas Girish just showed for the first time. It was not randomized, but still showing truly the potential of combination therapies for muscle-invasive bladder cancer, except the surgery. I'm going to show what we're dealing here. And as a patient who came through the clinic, classical, and just show how dangerous this disease can be and where some of the decisions are tricky. 48-year-old gentleman, lovely gentleman, with a lot of comorbidities, type 2 diabetes, hypertension, massively overweight. I think actually he was 320 pounds. Unfortunately, relatively typical for those who work in North America, not unexceptional. And with carcinoma inside, that's back in July 2014. Metastatic workup negative, got BCG second, and then has a TURBT in May 2015 with cytology and carcinoma in situ. Clearly BCG failure. And then, we'll discuss later about the different options, got EMDA, which is electromotive diffusion of mitomycin C and BCG in a protocol, kept having urothelial carcinoma, still urothelial carcinoma, and then boom, never ever was found with T1 or T2 or nothing, and just showed up with multiple lesions in the bone, multiple lesions in the nodes. And it's not unexpected. We see this from time to time. It just stresses how important and how dangerous the disease is. The nodes were biopsied and came back positive for a very poorly differentiated carcinoma in keeping with urothelial. And that's how things have changed as well, and I'm sure that Matt will allude to that. A patient who was metastatic actually was randomized in between Gemcis versus durvalumab and a CTLA-4 inhibitor, and I saw him at a bladder cancer session for patients where patients meet their physicians and actually are partaking in the guidelines for the country, which I think shared decision-making the way it should be, and it was completely clear. And again, just showing how aggressive the CIs can be, and when you fail BCG, it's really an issue. So we all know that BCG works, but we also know that BCG fails. And you have to be able to speak and to confront a patient, telling him, yeah, there's going to be about a third of patients progressing. And that means that when the window of curability is pretty narrow, and we look at all these different studies, the same thing, progression rate in between 16, 20, 30%. Now, one of the keys before discussing what to do when it fails is to define how aggressive the tumor is. And this is only meant, this laser I guess, yeah, to show this. I do stress that whenever you have a high-grade non-muscle invasive bladder cancer, you truly discuss, review the pathology, and ask specifically for variants, presence of lymphovascular invasion, because these are not the same animals. And for instance, our fellows before Thomas came looked at T1 and T2 disease, every single of these cases where there was a variant, even a couple of percent, was actually upstaged. And so it's not the same to talk about a T1 high grade, even with a tiny sarcomatoid or a tiny plasmacytoid variant and a T1. The devil is in the details. And not long time ago, it was about 3 weeks ago, I operated on someone where I really had to push. T1 high grade, failed BCG was sent. There was a tiny micropapillary component. We went to do the cystectomy. The PET scan was negative, and boom, there were bilateral positive nodes. Again, stressing the understanding of the disease as not one single unit. Now, how do we go from there, and how can we improve? In muscle-invasive bladder cancer, we now know that there are different components. Of course, the papillary, the basal, and the luminal. We now know that the basal respond more to chemotherapy, most likely, and the luminal less, but they have a better prognosis. And you also know now that there are several consensus about how to classify and fine-tune the classification of these muscle-invasive bladder cancer. I won't say anything, but there's a paper where many of us are collaborating submitted where all the data from the TCGA, the MD Anderson group, the North Carolina have been merged, analyzed by a group in Paris, and came up with a classification that gathers over 1,000 patients and where hopefully there will be some guidance for everyday's practice. In non-muscle invasive bladder cancer, we're not there yet, although many of the groups intend to do the same, so that next time when someone fails BCG, the first question would be, did he even need a BCG, and was there not something else that could have been proposed up front? We know that the non-muscle invasive bladder cancer can also be divided in several groups. This is a large series, European, showing that actually there are 3 grades, real 3 grades, in non-muscle invasive bladder cancer, and some of them absolutely don't respond. Our group has shown the same, so that RNA sequencing can define, a little bit like you saw in the TCGA for muscle invasive bladder cancer, 3 groups of patients, I'll skip that, where very obviously there's a grade 1 that never progresses, but there's a grade 3 that has a really high grade progression. And we merge these data with the Edegard paper on close to 350 patients showing exactly the same thing, which means that it is likely that the same way that we treat differently muscle-invasive bladder cancer going into the luminal, basal, and avars, in, I guess, about 1 or 2 years, we will discussing with our patients as whether a 40 to 50% chance of progressing up front with BCG is the right way to go, and probably spare. I know it's not what to do when you fail, but you don't fail if you don't propose up front what you shouldn't get. So why do people fail, of course? Either you understage, large volume, inadequate binding, you don't drive the Th1 type helper cells with IL-12 interferon gamma, and many other, including cell exhaustion and anergy. And I think it's also important to define 2 things: the BCG refractory, where there's persistence of recurrence of disease at 6 months despite adequate BCG, or patients who progress as early as 3 months, compared to BCG relapsing that can be an early, intermediate, or late relapse, including after 12 months. These are 2 different things. Now, because so many patients fail BCG, because the options are so limited, and because it's very difficult to envisage a randomized study, the FDA has exceptionally decided that it would be possible to give approval based on single-arm studies in this specific field. And the consensus, however, was that these trials have to hit a benchmark, and there were a couple of consensus, but basically you need to have a progression-free rate of at least 30% in 12 months and 25% in 18 months. That's a low bar. I think we can discuss as whether it's even acceptable, but that has what the FDA has decided to accept in single arm in the absence of randomize. So what are the options? I'm gonna actually basically show you the different avenues, what is possible nowadays and what is currently under investigation. It can go from the use of course, adenoviruses, immunotherapy with some enhancer like the IL-15, of course, the immune checkpoint inhibitors, whether it's Pembro or Atezo, which are now in BCG Failure, but also some of the intravesical chemotherapy, especially combination like cabazitaxel, gemcitabine, and cisplatin, not even to mention some new compounds like vicinium that have been studied. So it goes all over the place. Part intravesical chemotherapy in combination, immunotherapy or gene therapy. So if you have a late failure, many people in North America, I don't know whether you use interferon and BCG. Some people still use it in North America, and especially for late relapses, and that was shown a couple of years ago. However, you still face a recurrence-free survival of only 45% in 2 years. So you still have 50 or 60% of the patients who are failing. And that's why probably it hasn't been really adopted widely. The chemotherapy has had a kind of renaissance with the BCG failure group. Skinner used first gemcitabine. We had been using, actually, personally, gemcitabine already in the late 90s in patients who, I don't know if you remember, I just will go quickly. We had this crazy group of patients who ingested Chinese herd nephropathies, ended up in kidney failure, were transplanted, developed tumors in their bladder that we published, and they were immunosuppressed, of course, and at that time in the mid-90s, everybody was afraid to give actually BCG. So that we actually gave them intravesical gemcitabine with fairly good responses at 2 grams. Here, Ella just showed that 2 grams of gemcitabine can achieve some control of the disease. But again, look at the recurrence-free survival at 2 years, 24 months of 21%, which is okay, but certainly not earth-shattering. The gemcitabine has been compared to BCG, for instance, here. And that was another study, which is already about 7 or 8 years ago, showing some advantage of gemcitabine compared to the standard treatment. But again, only 20 to 25% at the end of the day that you would be saving using this kind of treatments, which are single intravesical chemo. This is why some people now have decided to add a combination of intravesical treatments. Gary Sternberg in Chicago was adding 1 gram of gemcitabine in 50 milliliters of water with docetaxel, with complete responses of roughly 50% at 1 year, 30% at 2 years. This is some of the protocols that we personally use, 1 gram with docetaxel, with some reasonably good results, but I think it needs to be studied. One key thing is if you use the gemcitabine, you really have to alkalize with sodium bicarbonate. You can't just give it without alkalization. Otherwise, if you don't reach the pH, then it's too acid and it really has to be buffered. Finally, you can add more and more. So I showed you the single installations, the combo, and now cabazitaxel and gemcitabine and cisplatin chemotherapy intravesically. Very early results. I haven't seen any further data from the gastro, but out of 9 patients who were unresponsive, 7 actually were in complete control. But I really would like to see the side effect profile and longer data. Now, how can you even increase and improve the intravesical BCG? Well, you can enhance its action. Here, at the ASCO was presented a study where BCG was given with an enhancer of the IL-15, which basically then would stimulate the, it's an agonist of IL-2 and then of the Th1 pathway, and leads to enhanced activity of the NK cells, of course, and tumor cell killing. Interesting results to be seen. There's been a lot of discussion. I'm sure you remember this comes from Colin Dini's group at MD Anderson, where they use here an adenovirus to actually have a drug which would be basically the interferon. And they also teamed up with a company from Finland. Why that company? Just simply because they had a surfactant that would increase the penetration so that their adenovirus then would replicate an increased efficacy in the bladder. And the study actually was a nice study where it was a dose-dependent study. A couple of patients were excluded, but nevertheless, if you look at the data, and that's the durability of the high-grade response, you see a interesting amount of complete responses. And again, hitting the bar of 41% at 1 year, which would be actually what the FDA requires, but again, with a price of, that's a price. And I'll show you our own data. People, of course, miss the window of curability, progress, and of course, die. And that's really the thin balance that we're working with. Pembro and, of course, immune checkpoints are actively investigated in the field. Ron DeWitt, but also Girish at our center presented at ESMO the phase 2 keynote 057 trial. It was a single-arm phase 2 study of the efficacy of Pembro in patients who were BCG unresponsive. They used high-grade, non-muscle invasive CS in combo with papillary or just alone, and those people had to have BCG therapy in inadequate induction plus maintenance. And they accrued a reasonable amount of patients, 100 patients, with a median follow-up that was 9 months. At 3 months, and they had a central path review, which I think is really important, and also a central assessment. The complete response rate was 36.5%. I probably would say that they, especially for CIS, you're probably better off waiting up to 6 months to have a complete response. 3 months might be slightly too early, but still something which is certainly interesting. And a proportion of people who actually sustained their response of 85%. But that comes with a price. And the price are the side effects that some of us as urologists may or may not necessarily be very familiar with, which are the side effects of the immune checkpoints. Of course, diarrhea, pruritus, hypothyroidism, and arthralgia. I'll finish by showing how using devices you may eventually improve the penetration of some of the intravesical chemotherapy. This is our experience with EMDA in Toronto, where we had the sequential administration BCG and mitomycin C for patients who had failed BCG. There was a prior small series from England with some interesting data, about 30 patients, and we decided to embark on that and presented this last year. We followed the protocol that was established by Stasi and had the classical endpoints for the study. That's the way it works. Basically, skin electrodes are placed, a catheter is placed in the bladder, mitomycin C is actually instilled, and the electrodiffusion will clearly, hopefully, increase the penetration of the drug inside the wall, a little bit like hypothermia would do the same here. It's a current that does it, and this is the protocol. The results are interesting, although I certainly will bring a word of caution here. So we had about half of the patients with carcinomyosarcoma, 27% of PT1, median age 63. And so if you look at those data, you would say, that's not bad. I mean, 79% of progression-free at 1 year and 61% at 2 years, with a median survival that hasn't been reached. So we would say, that's good. However, and that joins what Colandini showed with his adenovirus, what at the end of the day many people showed. Yes, many people were spared a cystectomy or something more aggressive, but look at the number of people in our series who died from bladder cancer, 6. So 20% died. And so it just means, yes, you save bladders, but yes, you put also patients at risk. And I think as long as we're not really able to define who these people are, we don't know how to act, it's tough. I mean, I wish we had a Stampede trial where we could have standard of care versus for BCG failure, but I don't think we have standard of care, which means that it's really difficult to compare things. And I really bring this, I hear too often, oh, it's a great treatment, blah, blah, blah. Yeah, it's true. 70% were without progression, but 6 people, 20% died. And so difficult to come up with a very strong and robust conclusion. Finally, you can use thermal chemotherapy. So rather than using a current to pump the chemo into the wall, you can use thermal effect. And this is a paper which was just published of a randomized study. And I think they truly should be commended for embarking on that study, where 48 patients had hypothermia with mitomycin C. There were two type of machines. One is Synergo, the other one is another type of chemo. And the other were standard of care or second course of BCG. There were a couple of crossovers, a little bit of imbalance between the two groups. This is the baseline characteristics, and you're going to see that again, about half of the patients had CIs only, which is probably the type of patients that we're targeting specifically. And these are the data. So basically, no difference. Now, pre-planned analysis, so I'm going to listen carefully to what Noel said. If you have a randomized study, you have a pre-planned analysis, but then I want to know how many patients. On the pre-planned analysis in patients with CIS, there was a difference in favor. I personally think that, I mean, interesting, but still not, needs to be validated. Patients without CIS, also a difference, although it didn't reach statistical significance. Price to pay, some side effects, and I think many, do you have hypothermia chemotherapy? So we've sent patients, we've seen many of these patients may have some side effects where you have part of the bladder wall which is kind of burned and may lead to some a little bit longer term side effects, although most of the time they're resolving by themselves, but it's something to keep in mind. Everything has got a price. And so these are the results, the end results. And finally, a multi-center study for chemotherapy, 150 patients here, in patients who were unresponsive, the 50 here, a complete response at 6 months of 46%, and a cystectomy-free of 71%. So the conclusion is that I think we probably should do a better job to define who are the patients who will respond to BCG up front, rather than losing time. I showed you the importance of some of the features like variants, lymphovascular invasion, and others. I'm reasonably confident that in the next 2 to 3 years, We will move along some classifications, transcriptomic or DNA-based, that will help us define responders. In patients who have had responded to BCG, probably, and if they have a late relapse, it's not unreasonable to combine it with another kind of immunotherapy. Otherwise, you're better going for new treatments. We do use personally a reasonable amount of gemcitabine or in combination or not. And at the end of the day, probably clinical trials are the best options, so that every single patient should be probably discussed and encouraged to participate in a clinical trial, but also be warned that if you miss the window of curability, the odds are high that unfortunately they would become metastatic or would have a very bad outcome. Thank you.